and sign out before the end of the webinar. Also, if you wouldn't mind shutting off your screens and muting yourselves in order to ensure the best quality. So medicine at its core is about caregiving. Empathy and compassion are essential. When the empathetic connection between patients and healthcare providers is broken, both the patients and the healthcare providers suffer. Patients receive worse care and healthcare providers burn out. This is why we're here today talking about healthcare ethics, humanities, and social justice, and the importance of incorporating all of these topics into medical education. Today's session will focus on international medical ethics in the wake of COVID-19, which is a very timely and important topic. We are pleased to have so many of you joining us today from 17 states and 12 countries. There are no financial disclosures or conflicts of interest in today's webinar. And again, it is my pleasure to introduce our two speakers. First is Dr. Stacy Gallin, who is the founding director of the Maimonides Institute for Medicine, Ethics, and the Holocaust. She is also a visiting professor at New York Medical College in the Biomedical Ethics and Humanities program, and the director of the Center for Human Dignity and Bioethics, Health and the Holocaust at Misericordia University. Dr. Gallin is the co-chair of the Department of Bioethics and the Holocaust and the faculty member of the Department of Education of the UNESCO Chair of Bioethics. Through her role with UNESCO Bioethics, she has been part of the organizing committee for the series of international webinars focusing on the global ethical response to COVID-19, along with Davidson College star basketball player Kellen Grady. Dr. Gallin recently started a social justice initiative called College Athletes for Respect and Equality, also known as CARE, with the goal of educating and empowering athlete activists to use their platform to help promote equality, justice, and tolerance for all people. She is also a contributing author to the Globe Post. Our second speaker today is Dr. Earlexia Norwood. Find solutions, not excuses, is her mantra. Dr. Norwood is a board-certified family medicine physician who has practiced at the Henry Ford Health System since 1993. She seeks partnerships and alliances to make Detroit the healthiest city in the country, as well as opportunities to educate communities and organizations on health and wellness. Dr. Norwood is currently the Service Chief of Family Medicine for the Henry Ford West Bloomfield Hospital, Director of Practice Development and Community Health Education, Ambassador for Healthcare Equity, and Global Health Ambassador for the Breaking Walls organization. It is my pleasure to turn the program over to Dr. Gallin.
Thank you very much, Ms. Elman. I really appreciate being here today. So the topic that we're going to be focusing on today, medical ethics and in the wake of COVID-19, obviously is something that we are all very interested in learning about because it is extremely relevant to all of our lives. So at the end of the activity today, participants should be able to identify the international ethical challenges brought to light by COVID-19, reconcile the unique challenges of the COVID-19 pandemic with the ethical responsibilities of healthcare professionals, and understand the importance of adhering to bioethical principles to guide national and international policy and practice. Next slide, please. One of the important things to understand about this particular issue that we're dealing with is that it is not something that is unique to our country. And that's one of the things that makes the COVID-19 pandemic something that is really important to understand from the global level. So when I talk to my colleagues from other countries, it is really interesting because it's something that we're all going through. And there's a spectrum of care, I would say. And, some people kind of are experiencing things at different times, but it's not something that anyone has been able to escape. So these questions that we're dealing with, these questions that we have to struggle with, although none of us have really faced them before, there are certain ethical issues that can guide us. And it's been very enlightening to see how different countries, different cultures, different regions have dealt with these issues and what the guiding factors have been. So some of the questions that we've been dealing with, you can see in times of international crisis, what happens when there are not enough resources to help everyone that needs assistance? I think that's one of the things that we're really facing right now is a lot of times, we'll see something that happens in our country. We'll see maybe, a hurricane, or we'll see, even somewhere internationally, we'll see an earthquake, something like that. And the rest of the world rallies around that one geographic area because we may have the resources that they don't have. So we can provide that type of aid. But what do you do when everyone is facing the same crisis at the same time? How does the field of bioethics guide healthcare policy and practice in an instance such as this one? Although the principle of respect for human dignity states that all people should be treated equally solely by virtue of being members of humankind, what happens when we must ration life-saving medical supplies, when we don't have a choice? Is there a hierarchy of human life where certain people are given treatment ahead of other people? And if so, what is it based on, and who is responsible for making those decisions? And I think one of the things that it's kind of hard to see right now because we're in the midst of this global pandemic, but how will the decisions that are made right now, today, during this COVID-19 crisis affect the future of humanity? When the crisis passes, what happens then? When we're on the other side of this, what is going to happen? Next slide, please. So where are we starting from? I think that's something that's important to understand. And I realize that many of the people here today are familiar with this concept, but I do think that it's important to review. The basic goal of healthcare is, this idea of this dyad between the healthcare practitioner and the individual patient, right? So it's the relationship between those people that is at the heart of healthcare practice. So when we're talking about traditional medical triage, that's a concept that came from Napoleon's chief surgeon, who decided that in times of war, medics should make their decisions based on some type of an organizational structure, right? So they would care for the most critically injured first, regardless of their military rank or distinction. So on the battlefield, those things were removed, which is interesting if you think about it. That kind of, even during that time, they were saying, no, we're not going to kind of care for people based on their stature or their status. We're going to care for people based on these three major categories. We are going to look at those who are unlikely to survive even without care, those unlikely to survive even with care, and those who will survive with care but without care. And of those three major categories, once the wounded were broken up into those three major categories, priority was given to people in the third category, because when you have scarce resources, you want to give them to the group that will make the most difference. And I'm glad to see that actually this is not something that everybody knew. A comment just came in, so I'm glad to hear that. So one of the things, that when you look at what's happening now versus kind of a wartime triage situation, the difference is there's really no definitive beginning or end here. And again, why is there no definitive beginning? Because when you're looking at the global scale, the outbreaks of COVID-19 started at different points in different areas of the world. So what do we do? Can we still apply this same idea of traditional medical triage? And I think what we've seen, the answer is no, we can't. That's where the problem comes in. Next slide, please. So as Ms. Ellman said before, I do a lot of work with UNESCO's chair of bioethics. So UNESCO is the educational arm of the UN, and their guiding bioethical principles come from the Universal Declaration of Bioethics and Human Rights. So Article 3 is the first one, which I realize doesn't make sense, but just go with it. And Article 3 states, human dignity, human rights, and fundamental freedoms are to be fully respected, right? They're very upfront about that. There is no wiggle room. And the interest and welfare of the individual should have priority over the sole interest of science or society. So that is really the starting point. That's where we're coming from. And I think if you look at a lot of these universal declarations, first of all, you can see, and again, it's important to put right up front that everyone's background, everyone comes in with some type of bias. And I'm not using bias in a negative manner. I'm saying that, everyone's views are shaped by their life experiences. My history, my background is in bioethics and the Holocaust. So I can tell you that a lot of these declarations, codes of ethics came out of the ashes of the Holocaust. So you can understand where some of these things are coming from. The Holocaust being this unique example of medically sanctioned genocide, where you can see really this abrogation of ethics on the part of the medical and scientific community and wanting to ensure that something like that never happens again. So when we're looking at what can guide us, where can we go? What can we turn to? This is a pretty good example of basically where all of these universal declarations, where they stand on these things. And I'm going to turn it over to Dr. Norwood now to speak a little bit more about the guiding bioethical principles.
Thank you very much, Dr. Gallin, and good afternoon and good morning to those who are joining us from other locations. This bioethics is a large area, and I just want to make sure that we have the backdrop. We're discussing this in the light of COVID-19, which gives us a framework, if you will. When we think about where we currently stand with COVID-19, I live in Michigan. There's lockdowns now currently occurring again in France and in Germany due to COVID-19 rates increasing. Here in Michigan, we've got 175,000 cases, and with over 16,000 lives being taken. I'm sorry, over about 8,000 lives that have actually been lost to COVID-19 here in Michigan. But in the nation, when you think about where we are, over 200,000 lives lost and over 8 million cases occurring, it's a significant number to say that it's not hard for our health systems and resources to be overshadowed by the burden of need. So here are 4 principles of bioethics that I think are important for us to talk about. Autonomy, beneficence, non-maleficence, sorry, having a problem getting my words out, and justice. So when we talk about autonomy, that's looking at the patient's right to choose. A patient always has the right to choose care or to refuse care. And there are many instances I can tell you in healthcare where physicians want patients to always receive care because we feel as if in many instances that providing care and saving someone's life is the right thing to do. But there are times when that's not the best decision. And it may be the best decision in the view of the provider, but not in the view of the patient. So as long as the patient has clarity and the ability to make their own decisions, they have the right to choose care or to refuse care. When we look at what the second major principle is, the beneficence is saying that no matter what, we're going to do what's the right thing for the individual, the right thing for the patient. So keeping the patient first is a major part of most healthcare systems and the principles of bioethics. And for our third principle, non-maleficence, that's the heart of what medicine is. everyone says to do no harm, but I want to make it clear that the parallel of that is that there's always an opportunity to do harm and an opportunity to do good. So when we say first do no harm, it's with the recognition that some of the actions we take that may look as if they're beneficial may not give benefit, but may actually cause harm. So to be cognizant of that as you're making decisions. And of course, when the last element being justice, that we want to make sure that there's fair allocation of resources and that patients who have familiar backgrounds and familiar, very similar conditions have the same access to care and to resources. Next slide. Well, we've got some history of disasters that have occurred in the US and around the world. Many of you have sure remember the Hurricane Katrina of 2005. There was a physician who actually felt that they should make the decision as to whether or not certain patients lived or died, and gave certain patients lethal dosages of medications because of concerns that those were not the individuals that they should try to save and salvage in the process of Hurricane Katrina. In Japan, there was the earthquake in 2011, where there were some babies that were chosen and individuals to be removed for days, and others that were left behind. So that was making a decision as to who would live and who would die. In 2009, here in the US, with the H1N1 pandemic, there had to be decisions made about patients who would receive heart and lung bypass machines, because those machines are not readily available. And in 2014, in Africa, in West Africa, the Ebola outbreak, which we also heard quite a bit about with concerns of Ebola coming to the US in 2014, healthcare providers could spend only short amount of times in protective gear and then would need to decide who they would work on and who they wouldn't. And I'm sure some of you can relate to that even today, where we're talking about the coronavirus and individuals being in ICU units and biohazard suits and masks and gloves and heavy equipment to protect them potentially from the infection. So we're seeing a little bit of that even today. And of course, I like that example that Dr. Gallin gave in reference to the Napoleon choosing the individuals who were more likely to be saved and not based upon their wealth or their rank. So when we think about how this may play out across multiple platforms in the US and in other countries, there are different standards, and we'll talk a little bit more about that. But another one that I want to note for us in the US that occurred is even with the Tuskegee experiment. So we knew from that experiment, the decision was made to provide care differently for a group of individuals, and it was purely based upon race. So we have examples of how care has been distributed in unethical ways. So now I'll turn it back over to Dr. Gallin.
So when we talk about COVID-19 and the unique challenges for ethics and human dignity, when we started this webinar, one of the things that I said was COVID-19 obviously is unlike anything that we've ever seen before. And one of the things that makes it unlike anything we've ever seen before is that it is happening on a global scale. And that as a result, there really isn't any way for us to go to our colleagues in another part of the world and say, hey, we really need your help, as we've done with other types of disasters, like the ones that you saw on the screen prior to this. So human dignity should be at the center of ethical medical treatment. That is a blanket statement that in theory, I think most people can get behind. The problem is, how do you translate theory to practice in a situation like this? And so one of the things that I want to make sure we're very clear about is I think that everybody is trying their hardest to live up to that ideal of keeping human dignity at the center of ethical medical treatment. I think that the problem is exactly what this slide says. This is a unique situation that we've never dealt with before. And it's a time-sensitive situation that we've never dealt with before. So what do we do? COVID-19 has presented new challenges for respecting the human dignity of all individuals and protecting their human rights. We want to do it, but we don't know how to do it, right? These challenges include the allocation of scarce resources. When we talk about the allocation of scarce resources, I also think it's really important to point out that for a lot of time, I would say in the spring, I was hearing a lot about ventilators. What's going to happen when we don't have enough ventilators? But I would make the argument that ventilators are secondary in this particular situation. If we're not protecting our healthcare professionals, if we're not giving them the proper PPE, which I am doing this presentation today from my home in New Jersey, and I live not far from New York City, which, as you all know, in March, April, May was really the epicenter of the outbreak here in the US. We did not have proper PPE to offer our healthcare professionals. If you don't have the healthcare professionals to operate these ventilators, that is a big problem. So when we talk about the allocation of scarce resources, we're not just talking about, I think what people think about as like being tangible materials. We're talking about actually caring for the people as well. The challenges also include access to care. Access to care has been a problem in our country for years and years and years. And we haven't really been able to figure that one out. So all of a sudden now to have to do it under a tremendous amount of pressure during a global pandemic becomes much more difficult. And the availability of vaccines or treatment, should we get to that point, what are we going to do with that? How are we going to figure out who gets these vaccines or these treatments in a fair and equitable way? How can we reconcile the unique challenges of this particular pandemic with our ethical duties as healthcare professionals, but also as moral agents, right? And that's really important because we have to remember that we're both. So the last NEH webinar, for those of you who participated in the last webinar that we did, we talked about the importance of social justice and advocacy in medical practice. And that, again, you'll see kind of comes up in this topic as well, right? Because this is another situation where you have to be both. You have to figure out how social justice doesn't get lost in this global crisis. So this quote here, I think, is a good one. The choice to set limits on access to treatment is not a discretionary decision, but a necessary response to the overwhelming effects of a pandemic. The question is not whether to set priorities, but how to do so ethically and consistently, rather than basing decisions on individual institutions and the rest of that quote. Individual institutions, approaches, or a clinician's intuition in the heat of the moment. So you can go to the next slide. But basically what we're saying here is we don't have a choice, right? We know that we want to be ethical. We know we want to do everything we can, to ensure that we're making ethical decisions, but we're also in a really, really difficult situation. So how do we kind of deal with those two things that are bumping up against each other? And the answer to that, in many ways seems to be guidelines, coming up with these guidelines. So why do we need guidelines? Why do we need to have these in place? There's a few reasons that seem to be the most common. So the first is it relieves stress on the individual physicians and it eases their mental burden. We have seen a rise in the number of suicides among healthcare professionals that are dealing with this. I can only imagine how difficult it must be. And again, one of the things that I want to stress is no part of this presentation is meant to place blame on the people that are on the front lines having to deal with this every day. It's just meant to provide some type of discussion, an arena for discussion. So that's part of the reason why we need guidelines, because we can't leave this all to individual physicians. It's too much. The second is it provides guidance for institutions and it encourages leadership and a chain of command. Physicians need to go where do we go? Who is in charge? Who is determining what the decisions are going to be in something like this? And again, not to keep going kind of with this analogy of like this wartime, because I don't think that is fair in every case. But in this one, it is, there is the idea of chain of command is the same, in a wartime scenario. So I think you need to know kind of What are we supposed to be doing? Who do we go to? And how is this all going to work? And three, I think, is really important. It goes back to Dr. Norwood's point. We need to provide transparency and establish clear standards of care in order to build trust within the community. We have too many examples, not only within this country, but throughout the world, of unethical treatment. And when you see high pressure situations like this, it is easy for people to think, why would I go to a hospital that is not going to care for me the same way they are going to care for other people? And if we don't have clear guidelines that are transparent, that is only going to increase kind of that idea of, well, what's going to happen? What am I dealing with? Is it just going to be people looking at me and making a decision based on that? How do I know what's going to happen and what to expect? How do I know that I'm going to be protected? How do I know that justice, that bioethical principle, is going to be upheld? And also, it protects healthcare workers and institutions from liability issues. And that goes back to the slide about the history of disaster ethics in healthcare and Dr. Poe, and kind of connects to number one. These individual physicians that are being asked to make these difficult decisions, like if that's not hard enough, they kind of have in the back of their minds what's going to happen from a liability perspective. So clear guidelines are beneficial to everyone, to the individual, the institution, and the community. Next slide, please. So the importance of ethics in a pandemic. Obviously, we just talked about the importance of creating clear guidelines that are easy to follow, but that comes at the expense of acting contrary to the professional goal of medicine, right? So we talked about this before, the idea of the dyad, the individual, the relationship between the healer and the person that comes to the healer at a vulnerable time, expecting that person to care for them as an individual, to advocate for them as the patient. But in this instance, we have so many competing interests because we don't have enough ventilators. So what do? Can you expect your doctor to say, well, no, you're my patient, so I'm going to make sure that you get the best possible treatment for you, which I think during normal non-pandemic times would be the expectation. But during the pandemic, it might not be, because there may have to be some type of a guideline that says, well, in this particular instance, we don't believe that in this triage situation, you would benefit from a ventilator as much as somebody else would. And so even though this would be the best course of action for you, we can't do it because, in terms of the societal good of society, because now we have to think about that too. It's not what we're going to be able to do right now. That's tough, right? That's a shift in terms of medical ethics in this paradigm that we have been taught to accept. And so hospitals have to be thinking about creating guidelines to help medical professionals make decisions in the moment. So, as I said, there's a lot of medical factors, and that takes time to really figure this stuff out. What are we going to do? What's the best course of action? What factors do we have to weigh? But in a global pandemic, there is no time. So how do we do that? How do we kind of deal with these very high stakes? And again, that's where kind of guidelines can come in and be helpful. And utilizing established best practices is important for crisis management. However, we don't have best practices for a situation like this because we never faced a situation like this. So when we're creating these best practices, we really have to be mindful of remembering the moral arc that we're dealing with. Because even though we have not dealt with a global pandemic like this, we still have to remember that regardless of what it is that we are facing, right? We live in it, there's a context. We live in a society, and medical decisions and scientific decisions occur in the larger context of the goals and purpose of medicine, which is healing others within society and helping society. Next slide, please. So let's talk about the international response for a moment. When this kind of first hit on a large scale, originally, we were dealing with China and Italy as the two countries that really, got hit the hardest first. So originally in China, sick patients were being turned away from hospitals because they just did not have the bandwidth to deal with this. And there was a lack of transparency that created an issue. And I think that's how transparency became something, a buzzword that we all kind of said, hey, let's pay attention to this. I think more troubling for those of us in the field of bioethics was what happened in Italy, where the Italian Society of Anesthesia, Analgesia, Intensive Care and Therapy was forced to release a document called Clinical Ethics Recommendations for the Allocation of Intensive Care Treatments in Exceptional Resource Limited Circumstances, with the goal of offering authoritative, professional, and scientific support to those who are forced by daily events to make sometimes difficult and painful decisions. Now, you will see here the PR is in parentheses. And then you will also see in some other ones, R is in parentheses. PR is the press release. R is the actual resource itself. So right off the bat, you're seeing that there was a resource, right, that was released. That's the clinical document, the 15-point clinical document that I mentioned. But there was a press release that had to go along with that because things were that bad. Because people were saying, well, if you're elderly, that's it. You got no shot. And that's not really building trust in society. That's not what you want if you are either the hospitals in Italy who, are tasked with the goal of helping people, or the population in Italy who is thinking things, that aren't necessarily the case. So they had to put this document out because they really didn't have a choice. So that's a little bit more of the, responsive Monday morning quarterbacking that you kind of hope to avoid, but because of the way in which this all played out, really didn't have a choice. So you can see here, there were two purposes, A and B, to relieve clinicians from a part of the responsibility in the decisions-making process, which can be emotionally burdensome, carried out in individual cases. So that speaks to easing the burden that we were talking about before of the physician. And then B was to make the allocation criteria for the healthcare resources explicit in a condition of their own extraordinary scarcity. So again, that's to say, we're going to make this as transparent as possible. However, we're pointing out that this is an extraordinary condition. And so we're being forced to make choices we would rather not make. So greater life expectancy is privileged. So that means not necessarily having to follow a criterion of access to intensive care of the first come, first served type. Why does it say that? Because that is what they had previously been doing in an emergency room kind of fashion. You come in, you have a problem, you're the first person there, they're going to give you access to the resources that they have. They were aware they were not going to be able to do that. So they wanted to put that out there right off the bat. This is not the way that it's going to be. Next slide, please. So you can see this quote. So it is not CRT with this document of recommendations that proposes to treat some patients and to limit treatments to others. On the contrary, it is the emergency events that are forcing the anesthesiologists, resuscitators to focus the attention on the appropriateness of the treatment towards who can benefit most, where the resources are not enough for all patients. That comes from the PR portion of the document. And the purpose here is to say, we don't want to do this, right? This is not our choice. We don't, but we're out of options. This is an emergency. This is an event unlike anything we've ever seen before. We don't know what else to do, and we need to do something. This is the best we've got, basically. So the recommendation proposes an age limit. Then an age limit needs to be set, and the underlying principle is to save limited resources, which may become extremely scarce, and in fact did, for those who have a much greater probability of survival and life expectancy in order to maximize the benefits for the largest number of people. So together with age, the comorbidities and functional status of any critically ill patient presenting in these exceptional circumstances should carefully be evaluated. A longer and hence more resource-consuming clinical course may be anticipated in frail elderly patients with severe comorbidities as compared to a relatively shorter and potentially more benign course in healthy young subjects. So even though this was not, as you can see in the quote on the left, this is not what was intended. But what wound up happening was age became the lightning rod here because COVID-19's general impact on the elderly population, not known, to do as well as the younger population. But the problem is that 23% of the population in Italy is over 65. So if you put something like this out there, that's going to cause a serious uproar. And that is what happened. You had people start saying, well, that's not fair. That's not just. I'm not going to pass judgment on that. I'm just going to say, if you put something out that says age is a criterion for who is going to, have access to these scarce resources, there are going to be repercussions, particularly in a country where a quarter of your population is affected by that. So something to think about. Next slide, please. In the United States, so I will tell you that we have, at the end of this presentation, we have an overview of state, we have resources. I put this resource right on this because I figured people are not going to believe it. So this comes from this Wall Street Journal analysis here. This is how we're doing it in the US. New York State, at least this is how we were doing it in the US. Let me rephrase. When this article was published. New York State rejected the idea of giving healthcare workers top priority for ventilators in their 2015 plan, because that was the last time it was revisited, arguing they likely wouldn't be able to return to work soon enough to help fight the pandemic. In Michigan, healthcare workers were, it was argued that they should be at the top of the pecking order because they wanted to encourage them to keep showing up for work. In terms of age, so that's an instrumental value issue. In terms of age, in New York, they said patients age 17 and younger get priority when their prognoses are the same as those of adults. That's an approach followed in many states. In Minnesota, younger adults can be favored over patients at least 20 years older. In Oklahoma and Utah, offered little more than checklists and flowcharts that rate patients' odds of survival, leaving the decision-making mostly to doctors. Next slide, please. The intellectual ability, this is a troubling one. Pennsylvania provided lower treatment priority to people on the basis of particular intellectual disabilities. And Alabama prioritized treatment of able-bodied individuals over people with physical and/or intellectual disabilities. In 2020, that was on their actual record. So as you can imagine, that caused a lot of uproar and has since, those laws have since been changed. And you can see the bioethicist Ezekiel Emanuel says a state-by-state approach is totally inequitable. If there's anything arbitrary in life, it is where you happen to live. So in the US, our problem was that we didn't really have any types of guidelines that were standardized across states, or honestly, even within states, people didn't even realize that these guidelines existed. Next slide, please. So some common strategies for establishing guidelines. I think you saw some of these mentioned before. The first come, first served. The issue there is that favors those who live close to hospitals. The outcome-oriented approach, maximizing benefit, saving the most lives or the most life years. But exclusionary criteria there can be inherently biased, dealing with issues like institutionalized racism when it comes to the comorbidities that you're using. A random lottery that's not really based on any scientific evidence. A point scoring system, which is based on different criteria depending on the guidelines, what criteria are being used and who's choosing it. And instrumental value, we spoke about that before too, prioritizing those playing a valuable role in a pandemic, like medical workers. But how does that tie into societal worth? Who is considered instrumental and who decides? Because saying we're going to give frontline healthcare workers access to PPE, but not necessarily people that are working at the grocery store, who also have to show up for work every day because they play an essential role in our society, as you can see, could be problematic. Next slide, please. So there's a lot of ethical considerations here that you can see that we've already alluded to. They come down to all of these different issues. Again, when we're talking about protecting the human dignity, protecting equality of people, obviously, I do believe that this is something that we all want to preserve. This is something that we're all looking at. We're all trying to find ways that we can work through this in a fair and equitable manner, but we don't know how to do it, right? And we haven't had a lot of time. Now, in an ideal world, we would have had some time to prepare for this. And the one thing that I can say that I hope we come out of this with is an understanding that we need to do better and we need to be better prepared in the future. Right now, though, we have a lot of issues that we're facing. And next slide, please. I think the major question we want to think about is what will society look like when the crisis passes? Because whatever the characteristics are that we are using, they're going to have ramifications. If we say that we're looking at age or comorbidities, whatever it is, once we say this person, we're valuing this. If you are over, like they did in Italy, if you are over 65, you've now told 1/4 of your population as a country, that it is not worth saving their lives as much as it is worth saving the other 3/4 of the population. And you can't take that back. Once this passes, you can't take that back. So that's something that we need to understand as we're making these decisions, and we need to prepare for. And if we don't, then I think we might find ourselves with more issues facing us when we pass this crisis than really we're ready to handle as a society. So next slide, please. To me, the big thing is you can't abandon regular ethics for what I would call catastrophe ethics. The analogy that I'd make here is not to war, it's to sports. A regular season game and a championship game, the rules are the same, but the stakes are higher and the players are more skilled and ready to face the challenge. So a pandemic like COVID-19 calls on us to rise to the challenge of applying our pre-established ethical guidelines to make moral decisions when we need to the most. We have guidelines, we have ethics that have worked, that we have all agreed on, that are fair, that are equitable. We need to turn to those. We need to not abandon those because we are dealing with something that we have never seen before. Times of disaster don't call upon us to throw out these everyday values. They call on us to take them and to use them to deal with this situation. And with that, I'm going to turn it over to Dr. Norwood.
Okay, thank you, Dr. Gallin. So here are some basic recommendations where we can look at doing things in a triage with triage committees, regional. So what does that look like? For triage committees, for instance, the complete reversal of the physician's obligation to care for the individual patient, and instead to make decisions based on the greatest good for the greatest number of people. And we know when there's scarce resources, it does, the way that physicians need to think, the physician and healthcare teams need to think, does require a shift. The ease of the psychological burden of the clinician to be the final determinant is also helpful again, so that that primary care physician or ICU nurse isn't the one that's making the decision, so they can really permit themselves to do the care. And then of course, spreading the decision among a multiple person committee kind of removes one individual's burden, and it also it gives you the plethora of thought of individuals who can bring different dynamics to hopefully come to the best conclusion. Another way of doing it is a regional collaboration. And that's where you provide reliable confidential venue to identify and discuss and make progress on a regional challenge related to COVID-19. And we saw a little bit of this, I think, with COVID-19 with New York, New Jersey, Rhode Island working together. I'm not sure if Pennsylvania was also a part of that, but looking to see how they could work together to come up with a plan to help patients and help the citizens in those areas. Encouraging transparency and mutual supportive planning. It helps to support institutions where ethics centers are limited. So if one state or one region doesn't have a resource available, they can share in the resource with where it is available. Helping to clarify legal concerns up front too, and how care is being provided. It explores the development and consensus concerning regional standards of care, especially if there isn't state level guidance that's provided. It really helps to have something at least at a regional level where something can be done. And it helps to also identify emerging concerns that may call for a joint communication between governors and public health authorities. What I think is very, very glaring for us is when we think about with COVID-19, we really don't have a national guideline where we can say everyone across the country is required to wear a mask. Everyone across the country is required to have signs in their venues that no admittance is allowed in any venue without wearing a mask. Or everyone across the country, we have a total of 50,000 ventilators available, and we now are going to deploy those to this segment of the country because there are outbreaks there, and the outbreaks are lower in Michigan, so we're going to send more ventilators from Michigan to Florida, where there is a bigger concern. So if we have national guidelines and national collaboration around efforts such as this with the pandemic, then everyone is on one page and not moving from one state to another. For instance, my son who left Michigan to go to Arizona because Arizona did not have the same stringent recommendations in place. So he left Michigan, yes, my young son, to go to Arizona to get a haircut. Not the best use of resources. So being able to think about infections traveling across state lines simply because one area has more conservative measures in place and others don't, only allows that with those permeable barriers of state lines to take infections from one place to another. So that's where a national guideline would be very helpful and very beneficial. Next slide, please. Well, when there's a scarcity of availability of resources, there are different ways that we would look at. Maximizing the benefit is one way of using those scarce resources to think about how do we provide those resources to provide the best for the total lives or total years that can be saved. That's one of the 4 fundamental ethical values that can be used. Another is that we should treat people equally. Treating people equally can be done where you say, yes, first come, first served. But we also noted, as Dr. Gallin noted, there are some limitations in that. First come, first served doesn't work well if you live in a rural community and you don't have the ability to get to another resource quickly, right? Because it's 200 miles away from you. But you could be the one who needs the resource the most because of your illness. Promoting and rewarding instrumental value, and this is one that Michigan is doing, promoting and rewarding, giving priority to those who can save the lives of others and rewarding those who've done so. But one caveat to that is that wealth should never be a part of those parameters. To say that you have more money that you can help to send more money overseas, or you have more money to buy more access, is not one of our guiding principles. But giving priority to the worst off is one of those 4 principles, because we know that in some instances, we look at taking care of those who are most vulnerable, which can be the youngest or the sickest, are the ones that we would provide resources for. And when I think about these together, I think about when the United Nations was formed in 1942, and how First Lady Eleanor Roosevelt was one of our US delegate, was responsible for writing and putting together that first universal document when they had 2,000 delegates and over 18 countries represented as a part of that forum. And she was over the subcommittee to put together that first draft of the Universal Declaration of Human Rights. And that document, again, noting that all human beings are born free and equal with dignity and rights, and making sure that everyone, and just how hard that was to come up with that declaration, took over 2 years in order to draft, to simply say that all human beings are born free and equal with dignity and with rights. So for me, that's pretty profound, that to come up with that statement with 18 different countries would have taken 2 years to craft. So the fundamental rights of everyone. Next slide, please. Well, here are some recommendations, and I know we're getting close to time, so I'm going to move a little quicker here. Recommendation 1 is for simply to note that the value of maximizing benefits is most important, and that we have the priority of limited resources. We should aim at saving the most lives possible and maximizing improvements in individuals post-treatment with their length of life. So if the resources are scarce, we want to make sure that the people who are sick and who will recover, that they get the treatment priority. And those who are unlikely to recover, even if they're treated, are those that would be on the lower priority list. Next slide. The other is recommendation 2 is that the frontline healthcare workers, that we look and make sure that the critical care and the things that are needed for people who are part of the healthcare environment, that they have the resources that they need. Workers should be given priority, not because they are somehow more worthy, but because of their instrumental value. We see the same thing when the same type of strategy around when there are wildfires in Australia or in California or in the West, that we want to make sure that firefighters get prompt and quick attention, because they are in the midst of the pandemic of fires, for instance, where healthcare is needed for them to continue to fight that battle. And so that's not just related to COVID-19. Recommendation 3, for patients with similar diagnoses, equality should be invoked and operationalized, so that we can make sure that when the stage is equal, everyone has the equal chance of surviving, and that they receive equal care upon of how those resources are given. And that sometimes may be, you're both here, we put in a lottery and determine who becomes next, or the first come, first serve method. Next slide. And I do want to note, one of the key elements for us here in the US, when we start talking about health professionals being available, is our respiratory therapist. So when we could have 1 million ventilators, but you need to have individuals who know how to work and care for those ventilators with patients. So the limiting resource isn't the materials. Again, it's the individuals who are able to manage those patients and to manage that care. So recommendation 4 is looking at prevention. Prioritizing guidelines should differ by intervention and should respond to changing scientific evidence. I think about this when we started, even with the COVID-19, to wear a mask or not to wear a mask. And the recommendation was that if you didn't have any symptoms, wearing the surgical mask wasn't helpful for you, simply because the mask was meant more so to protect the infection from going from you to someone else. So if you weren't sick, you didn't need to wear a mask. It was the people who were sick that should be wearing a mask. And we changed that when we started to see that individuals who had no symptoms could also transmit the virus, because with them being asymptomatic. So we change information based upon information that we receive. So with this, on looking at vaccines, for instance, that younger patients should not be the priority, but for vaccines for prevention with COVID-19, that you'd want to think about those who are at worst or at increased risk, which would be those with chronic illnesses and with advanced age, being the individuals that you would want to get vaccinated first. But as we all know, when we're looking at vaccines, there's a whole history, again, around how medications and vaccines would be distributed, especially if individuals feel as if they're being the guinea pigs for a vaccine, then that raises another ethical issue. When we look at curative, and right now there is no cure for coronavirus or for COVID-19, there is no cure. But if patients have access to certain care, such as an ICU bed or a ventilator, they have a higher opportunity to live. So when someone is really ill, we want to make sure that rather than prevention, but providing the best treatment based upon their prognosis, that we look at who's going to have the best rate of survival. Next slide. Recommendation 5 notes that we want to make sure that people who participate in research are provide to prove that the safety and efficacy of a vaccine or therapeutic process, that they get some priority. Recommendation 6, that there should be no difference in allocating scarce resources between patients with COVID-19 and those with other medical conditions. So again, when we're looking at how we do and distribute any type of care, it's looking at it in its totality with all of those factors. The outcome of these recommendations should be the development of a priority or guidelines at a higher level of authority that would alleviate the physician or an individual in the moment trying to come up with what needs to be done.
Thank you so much. We have come to the end of the hour, unfortunately. We have a tremendous amount of resources. We'd like to give a special thanks to all of these wonderful people on this slide: the Geisinger Commonwealth School of Medicine, Misericordia, the National Endowment for Humanities, and just to reiterate, thank you so much to Dr. Gallin and Dr. Norwood. Obviously, this is a very important topic with probably could go on for a few more hours or days. So just a reminder, Sharon had put a evaluation form in to the chat. If you could please fill that out. We need that in order for you to get your CMEs or CEUs. And we do have our third webinar coming up next Thursday, Human Dignity and Human Rights in Medicine. So if you're not registered for that, please register today and we'll send that link to you next Wednesday. Anything else, Dr. Gallin or Dr. Norwood? All right, thank you again. Thank you for everyone who attended. And I will send a follow-up email with some additional information. Have a great day.
Thank you.
Thank you, everyone.